Okay, dear colleagues, now we have come to the discussion part, and I would like all the participants ask the questions to our speakers. I hope that Paul Foster is here. Paul, let me know.
Yes, I'm here.
Oh, it's fine. Can we see your face, please? Okay, Paul, because I have got some questions for you. And Xulan also, I will ask her to ask the questions. So, colleagues, Vladimir, do you have some questions from the audience? Boris? No?
Natalia, can I ask you a question about your last presentation?
Yes, sure.
It's very interesting, and I know that you're one of the pioneer in performing the SLT treatment in close-angle glaucoma. Can you tell me about your technique of this treatment and whether you perform it simultaneously with peripheral iridectomy, or it should be done late after some period? And explain, please, some technique features about this procedure.
Yes, thank you, Vladimir. This is the very correct question, of course, because we know that many special features of the SLT in primary angle closure glaucoma, of course. First of all, we don't perform simultaneously with laser peripheral iridectomy, of course, because we know that some complications may be due to LPI. And later, I hope Professor Gazard will discuss these complications. That is why we have to wait for at least 2 months before these two procedures. And we try to perform SLT only if the half of angle is open. This is very important. The results Indeed, we have been following the patients for almost 10 years, and we have that in some cases the results are even very nice. I got the question for, thank you, for Professor Paul Foster. The Russian doctors are interested if we should call this disorder as the primary angle closure glaucoma after the successful LPI or after the successful cataract extraction. Does this eye still have the primary angle closure glaucoma? What is your comment?
So the diagnosis is important because we know that the risk factors for primary open angle glaucoma and angle closure glaucoma are vastly different. And there's good evidence that the physical features and the natural history will differ. As you said in your presentation, the angle closure disease is a more pressure-dependent condition. It is less likely that you need to have very aggressive IOP treatment targets. And so for those reasons, I think it's very important that you regard these cases as primary angle closure, but after treatment having open angles. For instance, if you were setting a treatment target of 12 or 13 millimeters of mercury for a primary open angle case, you may accept actually pressures up to 22 or 24 for an angle closure case because it's a far less it's a more pressure dependent condition, and you don't need to strive for very, very low treatment targets in many cases. Obviously, if you start off with a pre-treatment pressure of 50 and the pressure goes down to 20, that's a very good result. Whereas if you have a primary open angle glaucoma case with a pre-treatment pressure of 21 and they're progressing, then you know you have to get that patient down to below 14, maybe 12 or even 10. So I think it really is an important idea to keep in mind that the two conditions are different.
Yes, of course, thank you very much. And I think that we also should keep in mind some other mechanisms of angle closure, like the carotid, as Xiol have discussed, and according to our data as well. Paul, and this is another question for you. How often should we invite a patient with a narrow angle, I underline a narrow angle, no primary angle closure glaucoma, but just a primary angle closure suspect, narrow angle? And how long should we observe him without treatment? Is there a risk that this patient will come back to us with primary angle closure glaucoma?
So a narrow angle is a normal phenomenon. I don't think it justifies medical follow-up. The risk, even in people who have iridotrabecular contact, which means a closed angle, the risk is relatively low. It's around 1 in 5,000 per year for having an acute episode of angle closure. So the likelihood of acute destabilization is low. The question of whether to follow them up depends very much on the economics of the healthcare system. I can illustrate that contrasting the UK and the US system. Now, in the UK, we have a large number of commercial optometrists who are legally obliged to provide a routine eye examination that includes assessment of intraocular pressure and an examination of the optic disc. So effectively, the UK gets that screening service for every patient over the age of 40, free of charge each year. And for that reason, it's not necessary for the hospital system to take on that workload. So in the UK, we would regard there being no need for routine monitoring of people with closed angles but normal pressure and normal optic disc. You can contrast that in the US, where there isn't the same free healthcare system available to the public, and actually then it becomes the economics that we've done so far would suggest that it's more appropriate that those people are monitored in an ophthalmological practice and maybe even have prophylactic treatment. So it depends very much on the way the system runs, the capacity and the reimbursement processes. So really each country has to make its own decision about that.
Thank you. Do you document the change of the anterior chamber? Do you take a picture of angle in your practice? Do you take a picture of the angle of in your patients, narrow angle?
So we've seen a dramatic advance in the technology available to us over the last 20 odd years, and we've moved from gonioscopy being a rather it's experience dependent, it's a challenging technique, and it's not easy to record objective data. Then we moved into the era of widely available biometry, so we could get axial length and anterior chamber depth, which is very useful. And then with the advent of anterior segment OCT, it's brought us to the stage where we can get objective images and we can store them. So in my practice at Moorfields, we'd regard anterior segment OCT documentation of the angle configuration as a key part of the initial workup and the medical record of a glaucoma patient.
Yes, thank you very much for your answer. And I've got one question for Xulan Zhang. The question is, if we consider a role of the choroidal thickening in primary angle closure glaucoma, how can we treat it? Do you think that the choroidal thickening is the necessary mechanism of angle closure, and can we treat this or just only take into account?
I couldn't get your questions. Can you?
Sorry?
I couldn't catch your questions.
How can we treat the thickening of the choroid? What can we do with this knowledge that the choroid may play a role in the pathogenesis of primary angle closure glaucoma? The doctors ask about this one. What can we do with the choroid? How can we treat this condition? Or which kind of recommendations may we give to our patients in regard to this new mechanism of angle closure? Okay. Okay.
Maybe a little bit accent, maybe confused. You mean how can I treat the primary angle closure with different mechanism? You mean?
I mean the thickening of the choroid.
Choroid. You mean thicker choroid? Oh, okay. Based on my study and the literature, I just propose a hypothesis that acute angle closure or primary angle closure may be mediated by smaller ocular dimension, including the short axial length and the narrow angles, something like that. And also plus the choroid thicker, okay? And because in clinical practice or study, you can find out if only we use the one theory cannot always explain how angle closure happens. So when you only use LPI or phaco to treat the primary angle closure, just only release the iris Bombay or the non-pupillary broad mechanism is not enough, because sometimes you find out even though the anterior chamber depth is still deep, but still have happened acute attack. And what happened? Maybe because something happened in the afterwards. Also, one studies I remember is in the Europe, they find out even though Chinese and the European, they have the similar risk factor like a short axial length, narrow angle, and the lens curvature is short, something like that. But the Chinese have the acute attack much more than the Europeans. So besides the anterior chamber perimeters to cause the angle closure, we believe something wrong, something happened in the backward of the eyeball. That is why we will focus on the study for several years, look at some perimeter in the posterior segment of the eyeball. That is why we do this. Actually, Dr. Quickly already proposed this hypothesis for many years, 10 years ago, they proposed this one. And based on my study, we believe that people worry about choroidal thickening is the result or the reason to cause the acute attack. But our studies will prefer to believe that it is the reason to cause that. I also can give you some phenomena to confirm my hypothesis is true. Because when you, for example, when you do the phaco or not the surgery, if the patient really nervous, okay, and then suddenly anterior chamber was shallow, and then you talk to him, and then make feel comfort or even give a mannitol injection, something like that. Half hours later, the anterior chamber and goes deep again. Okay, so what's wrong? What happened to make anterior chamber that goes so shallow? Something happened in the backward. Who made the pressure in the backward? You're nervous. The nervous made the autonomic system to stimulate it. So I think about the core, the uvea may play an important role on this one. Okay.
Thank you very much. I think that we should pay more attention to our patients in Russia. Maybe we have the same risk factors, and I believe that it is so. Professor Vladimir Nikolaevich, Boris Eduardovich, do you have some questions.
I have a question to Dr. Zhang. Actually, she mentioned in her presentation that sometimes she's doing phaco alone in these patients. However, there is a certain amount of patients that she's performing combined surgery, combining phaco with trabeculectomy. So my question is to Dr. Zhang. So how do you distinguish which patient will go for trabeculectomy with phaco and which one will go for phaco alone?
Okay. If the patient can do the LPI, if the patient have the cataract at the same time, then you can choose either LPI or phaco. That's enough, okay? If the patient, if you do LPI is not enough, you have to do the trabeculectomy. And at the same time, patient have a cataract. At this time, you can have an instance for do the combined surgery. But for the acute primary acute angle closure, in the practical in our practical experience, that if do the LPI or phaco alone, it's good enough to release the acute attack. We don't need to do the combined surgery. Combined surgery only for the pressure cannot control, mostly in the chronic angle closure glaucoma. And under the gonioscopy, you can see the synechia more than half or 3/3 or even totally close the patient, okay? For the acute attack, we don't need to do most of the time, we don't need to do combined surgery.
So if I rephrase you, if there are no peripheral anterior synechia, so I think it's at least what you recommend is just to go for phaco alone. And if
yes.
Peripheral anterior synechia that are covering more than half of the angle or so then you combine. Is that right?
Yes. But for the practice, you will find out even though the angle closure totally close until synechia totally close, you try the phaco only, some patients still have a really good IOP control.
Okay.
Do you have experience like that?
One more question. And what kind of combined surgery do you prefer? I mean, what kind of glaucoma surgery in case of synechias you perform? What kind of glaucoma step at this combined surgery?
If the anterior synechia very severe, what kind of the combined surgery? Okay, yes. you can combine trabeculectomy. What's the meaning? Okay, you can combine phaco, right? You can combine after phaco, you do the mix. You can combine the after the phaco, you can do the tube, or you can do the cyclofocal coagulation. I think all kinds of things you can do it as long as the anterior chamber volume, the space is good enough.
Thank you, dear colleagues. Of course, we will discuss this issue later. I'll come back for the discussion with the presentation of Clement later. Very important questions, of course. And now we have to go further and a very short break, just for 2 minutes, and we will go to the second part of our webinar.